Okay, I'm back. We're about to continue. Raise your hand if you're able to hear me clearly. All right, that's good enough. For those of you who are present, make sure you pay very close attention to what I am about to present. All right, so what we're going to look at this afternoon is the basics of ECG and cardiac monitoring. I've already touched on cardiac monitoring to some extent as it relates to the purpose, how many electrodes you're using, and what exactly you're looking at. Now, a cardiac monitor is a equipment that can provide dynamic and static monitoring of a patient's cardiac activity. It is not exclusive to only cardiac monitoring though. So if you have a cardiac monitor, it can give you a ventilation rate, you can get a pulse rate, you can get pulse oximetry, can get capnography, you can get a blood pressure. It has a AED mode and it has a manual defibrillator mode. So the cardiac monitor can do more than just monitor the heart. It can monitor vital signs as well. But as it relates to cardiac monitoring, it is for a patient with a cardiac history and complications, or a patient with a respiratory problem, or any patient that you consider to be critical, you will use cardiac monitoring. Now, as it relates to the basics of the ECG, before you can look at an ECG, you need to know what the waveforms represent on the ECG. Now, on this diagram, you will see multiple waveforms. You can see a P wave, can see a PR segment, you can see a QRS complex, an ST segment, T wave, TP segment, which we're not going to focus too much on that. And you can see your RR interval and your QR interval and your PR interval. So you need to know what the main waveforms represent on the ECG. And what an ECG does is it captures the electrical activity flowing through the heart in various directions, and then generate a graph showing that activity. Now, the first thing that you need to know is that this flat line, so wherever you see a flat line on your ECG, it represents no electrical activity, right? Or a decrease in electrical activity. So that's your flat line. All right, that's the first thing you need to note. Flat line represents no electrical activity or a decrease in electrical activity. Anything above the baseline is positive. Anything below the baseline is negative. So anything above the flat line is referred to as a positive waveform. Anything below is referred to as a negative waveform. Okay? And let's focus on the waves now. The P wave, the PR segment, the PR interval, QRS, ST segment, and T wave. We need to understand what these waveforms represent. And as I said before, pay close attention to what it is that I am going to explain now. So, when you see a P wave on your ECG, the P wave represents atrial discharge or atrial depolarization. So it is when the atriums are discharging current, right? Some books will say atrial depolarization or contraction, but you can see electrical activity, and it doesn't necessarily mean that the heart muscle is moving. So the P wave represents atrial depolarization or discharge. So it's when the atriums are discharging electrical activity. Now, after the P wave, there is a PR segment. So there is a decrease in electrical activity. Now, the PR segment, which is right here, represents atrial repolarization or atrial recharge. So the P wave is when the atriums discharge current. The PR segment, which is this flat portion here, is when the atriums start to recharge. Now, what that means is the current slows down, and the current is slowing down. I didn't get a response from anybody. The current is slowing down because it needs the heart needs to allow, sorry, the heart must have time to fill with blood, right? So when the electrical current is leaving the atriums, so that the ventricles can fill up with blood, then it moves into the ventricles. So it can't reach the ventricles and there is no blood inside of it, so it slows down, right? So that's the P wave and the PR segment. The Q, which is down here, the Q wave is a negative waveform. It might not be visible on every ECG, but it's a negative waveform. So QRS, the QRS complex on an ECG represents ventricular depolarization. So the QRS complex represents ventricular discharge or depolarization. It's when the ventricles are discharging current. Now, after the ventricle discharge a current, there is a decrease, and then we have another flat segment. This is the ST segment. The ST segment represents when the coronary artery starts to fill with blood. So the ST segment represents when the heart muscle takes its blood supply. It should be flat. So the ST segment should not be elevated and it should not be depressed. So in other words, it shouldn't look something like this. Let me use my pencil. The ST segment should not look like this. So it shouldn't be down here. That would be a depressed ST segment, and it should not be up here. It should not be elevated, and it should not be depressed. If it's elevated or depressed, it's an indication of a myocardial infarction or myocardial ischemia. It means that something is wrong with the heart muscle in terms of it getting its proper perfusion. So that's the ST segment. Let me clear that. Now, after the ST segment, you have the T wave. The T wave represents when the ventricle repolarizes or recharge. So the T wave represents ventricular repolarization or ventricular recharge. Note that when the ventricles are recharging, it doesn't completely loses its electrical activity, right? So that's the some of the key waveforms so far. There are other things that I need to talk about, but these are essential. So the P wave, atrial depolarization or discharge, when the atria discharge current. The PR segment, which is flat, is when the atria recharges or repolarize. Then we have the Qrs complex, which represents ventricular depolarization or discharge. Then we have the ST segment, where there's a drop in electrical activity. This is where the heart muscle will take its blood supply. And the ST segment should not be elevated. It should not be depressed. If it's elevated, patient could be having a MI. If it's depressed, the patient has myocardial ischemia. Then we have the T wave. The T wave represents ventricular repolarization or ventricular recharge. So these are your main waveforms: P, QRST, PR segment, ST segment. Now, some key things that you need to keep in mind, so listen carefully. Down here, where's my pointer? Down here, where you have the PR interval, which is the beginning of the P wave to the beginning of the QRS complex. The PR interval represents complete activity within the atriums. So it represents when the atrium discharge and recharge, or atrial depolarization and repolarization. So it's complete activity within the atrium. That's a PR interval. Now listen carefully and make notes. The length of the PR interval should not exceed 5 small boxes. It shouldn't be less than 3 small boxes, but it shouldn't exceed 5 small boxes. Just commit that to memory. It will make sense when I move forward. Just capture that information. The length of the PR interval should not exceed 5 small boxes, and it shouldn't be less than 3 small boxes. Capture that information. Right? So that's one. If the PR interval, so if the PR interval is greater than 5 small boxes, the patient has a heart block. So something is blocking the impulse if it's greater than 5 small boxes. So that's 1. 2, the QRS complex, the width of the QRS complex, which is right here, this space right here. The width of the QRS complex should not exceed 3 small boxes. Should be less than 3 small boxes. It shouldn't be greater than 3 small boxes. That's the QRS complex. If the QRS complex is greater than 3 small boxes, then the origin of the rhythm is ventricular. I will repeat that. If the width of the QRS complex is greater than 3 small boxes, the origin of this rhythm is ventricular. It means the rhythm is originating from the ventricles. Okay? And the final point to commit to memory is the P wave must be nice and round, right? So when you look at an ECG, the P wave must be nice and round in its appearance. If you note a P wave that is abnormal in its shape, so if the P wave looks abnormal, it means that the origin of the rhythm is atrial. Let me repeat that. If the P wave looks abnormal, the origin of the rhythm is atrial. It means the rhythm is originating somewhere within the atriums. It's an atrial rhythm. So that's your important pointers. The QT interval, I don't expect you to know much about it as EMTs. Just understand that the QT interval, which is where the QRS complex starts and ends, represents complete ventricular activity, right? So that's complete ventricular activity. Not something I need you to be familiar with as an EMT, definitely as an advanced or higher. It's something that you need to be familiar with. So that's your basics. Now, important points. All of this that I'm drawing a circle around represents one beat. So from P to T represents one beat. So the RR interval is the distance between your beats, right? It can be regular, it can be irregular. And the distance between each beat is what we will use to calculate the rate of the rhythm, the distance. Okay, so that's your fundamentals for the waveforms. Are there any questions at this time? Ask questions before I move on. If you don't ask any questions, it's going to be my assumption that everything is crystal clear. Yes, Miss Beckford, go ahead.
Sir, I didn't catch the part when you said if the width of the QRS complex is greater than 3 small boxes. I didn't catch what you said after that.
All right. So this is let me use a pencil that you can see exactly where I'm talking. So right here, whoops, right here is the width of the QRS complex. So that's the width. The width of the QRS complex should not be greater than 3 small boxes. So let's say the QRS complex is out here. Right? So this is where it is. This QRS complex that I just added would be greater than 3 small boxes. Once it is greater than 3 small boxes, it means that the rhythm is originating in the ventricle. So it's going to be a ventricular rhythm. You got that, Miss Beckford?
Yes, sir. Thank you.
All right. Are there any other questions? Yes, Mr. Jones, go ahead.
I was just making some notes. Can you state again what the RR interval signifies again, please?
That's the distance between two beats. So the RR interval is the distance between your beats, and that's the distance that we will use to determine the heart rate. Okay, any other questions? No other questions, we're moving forward. So let me go back to actual to best fit that I can move forward. Now, this is not a PowerPoint that you will have access to. So go back, review the recording. This is actually a paramedic PowerPoint. So you're not going to get access to this PowerPoint, but you'll have access to the recording. All right, now let's get to the ECG itself. So with that understanding of the waveform, let's look at the ECG now. Specifically the placement of the electrodes. Come on. I want the cardiac monitoring. Get to cardiac monitoring. Where is it? All right, here we go. Almost there. Electrophysiology, cardiac monitoring. This is where we need to get to. All right. So let's work here and then move forward. Now, I might not finish this today, but we should get to an important point. So with cardiac monitoring, we use 4 electrodes. Can use 5. However, we can only view 3 leads, and it's lead 1, lead 2, and lead 3. So let me get to a better picture where we actually have the triangle. Good. So this is a picture I want. Actual size. Let's see if I can zoom in on this and scroll down. All right. So this is the cardiac monitoring. It's 4 leads, but one of the leads is a ground lead. That's a green lead that stabilizes the current. When we're doing cardiac monitoring, it's upper right shoulder, left shoulder, left abdomen, right abdomen. Now, look at your lead 1. So lead 1 is from the right arm or right shoulder to the left arm or left shoulder. And this is the way I want you to think about it with cardiac monitoring. Think of the current moving for lead 1 like this. So if it's lead 1, the current is moving this way, right? And your limb leads, there are 3 limb leads, lead 1, 2, and 3. And they're referred to as bipolar limb leads because they have negative and positive. Now, wherever the current starts from is negative, and wherever the current starts from is negative, wherever the current ends up is positive, right? So this is how it works. Picture the current flowing this way. with a straight line. Forget about the arrows on the picture, just focus on the line that I draw through the heart. So that's lead 1. Now, wherever the current start, wherever the current end, you're gonna have a camera. So there's a camera here, right? So that's lead 1. That is lead 1. So lead 1 starts from the right arm or right shoulder, and it moves to the left arm or left shoulder. So lead 1 looks at the left side of the heart. So lead 1 is looking at the left side. Lead 2 is from the right arm to the left leg. So think of the current moving this way. So the current is moving like this for lead 1. Wherever the current starts is negative, wherever the current end is positive. And you have a camera looking at the heart on the positive end. So lead 1 looks at the left side of the heart. Lead 2 looks at the inferior portion of the heart. Right? Now, lead 3 is the left shoulder or left arm to the left leg or left abdomen. So picture the current moving this way, right? So your camera would be here. Camera is here. So lead 1 looks at the left side. Lead 2 looks at the inferior portion of the heart, and lead 3 looks at the inferior portion of the heart. So that's your 3 bipolar limb leads. Is that giving us a clear picture of the entire heart? That's a question. So if we're only doing cardiac monitoring, can we see a good picture of the entire heart? No, we cannot, because with cardiac monitoring, you're only looking at the left side and the inferior portions of the heart. So that's not sufficient for a patient that you're suspecting is having a myocardial infarction. Therefore, a 12-lead ECG would be required. And basically, what occurs with a 12-lead ECG, let me zoom out back to the best fit. What happens with a 12-lead ECG is the 3 limb leads are augmented to form 3 more leads. So they augment the limb leads to form 3 more leads, and they are referred to as augmented limb leads. So you get 6. So it then becomes 6 limb leads plus the 6 precardial chest leads, and we now have a 12-lead ECG, but it's still only 10 electrodes. So the point that you need to grasp before you move any further into the slide is that when we're doing cardiac monitoring, if we're using 4 electrodes, the green one stabilizes the current. The other 3 electrodes will form the leads, and we can only look at 3 limb leads, and these are bipolar because they have negative and positive. The leads that we will be able to look at is lead 1, which gives us a picture of the left side of the heart. Lead 2, which gives us a picture of the inferior portion of the heart, and lead 3, which gives us a picture of the inferior portion as well. Now let's move forward. Now, if we need to do a 12 lead ECG, the current needs to be augmented. Now, don't let me confuse you at this point. Just understand the process of how we get the augmented leads. So, with your augmented limb leads, you have AVR, AVL, AVF, and the AV is augmented voltage. Now, what happens with AVR is the current from the left arm and left abdomen or left leg combines and then redirect the current to the right side. So the right side now becomes positive, and at this time we now have a camera on that side, right? So it becomes positive, so there is now a camera on that side. So we can now see the right side. Cool. For AVL, so AVR right, AVL left, AVF inferior or foot. So it's inferior. Now for AVL, the current from the right shoulder or right arm combines with the current from the right abdomen or right leg, and then it is redirected to the left side. So we now have a camera looking at the left side. So there's a camera looking at that portion of the heart. Right? Now with the AVF, the current from the right shoulder or right arm combines with the current from the left shoulder or left arm, and it is redirected down. And then we now have a camera looking up at the inferior portion. Camera not drawing so well, but anyway, you get the idea. We now have a camera looking up at the heart. So AVR looks at the right side, AVL looks at the left side, AVF is inferior. Now, let's see if you can answer this question. So let's see if you're paying attention. So the first thing I want you to answer is, if I am doing cardiac monitoring for a patient, how many electrodes would I be using typically? So how many electrodes would I use for cardiac monitoring? That's the first question. Answer quickly. Right? So I would be using 4 electrodes or 5, but 4 is more commonly used in the pre-hospital setting. You'll see 5 electrodes in the hospital setting. So more commonly it would be 4. Which lead would be the ground lead, the one that stabilizes the current? Agreed. Good. Right? And they are labeled. So you have right A, you have RA, left LA, you have RL, LL. Know what that represents, but anyway, that's the easy part. Next question, if I am doing cardiac monitoring, how many leads can I look at? How many leads can I look at if I'm doing cardiac monitoring? That's the next question. I can only look at 3 leads. All right, good. So that's lead 1, 2, and 3. Which side of the heart does lead 1 looks at? Left, right? So the lead 1 looks at the left side. Which side of the heart does lead 2 and lead 3 look at? Right, inferior. Good. Inferior. All right. Which side of the heart? Now, if we're doing a 12 lead ECG, the limb leads are augmented to form AVR, AVL, and AVF. Which side of the heart does AVF look at? Inferior? No. Yes, AVF is inferior. Which side of the heart does AVR look at? Right side. And which side of the heart does AVL look at? The left side. All right, good. Now this is my question. If I am doing a 12 lead ECG, so listen to the question carefully. If I am doing a 12 lead ECG, which limb leads would look at the left side of the heart if I am doing a 12 lead ECG? Which limb leads would look at the left side of the heart? Not a complicated question. Don't want to delay moving forward. All right. So Miss Carr, correct. It would be AVL and lead 1. So AVL and lead 1 in a 12 lead ECG as limb leads look at the left side of the heart. We only have one that would look at the right, and if we're doing a 12 lead ECG, which limb leads would look at the inferior portion of the heart? So AVL and lead 1 is left side. Which leads would look at the inferior portion? Quickly. 2, 3, and AVF. So lead 2, lead 3, and lead AVF would look at the inferior portion. Good. So we have that understanding. Let's move forward. All right. Now the precardial chest leads. So let's look at the chest leads now. So we have augmented the limb leads to get 6 limb leads for the 12 lead ECG. So that would be lead 1, lead 2, lead 3, AVR, AVL, AVF. And we are going to combine that with the 6 precardial chest leads, which are numbered V1 to V6. Now listen carefully. V1, actual size. V1 and V2 looks at the septum of the heart. So V1 and V2 look at the ventricular septum, which is anterior. V3 and V4 looks at the anterior portion of the left ventricle. So V3 and V4 is also considered anterior leads. So that means V1, V2, V3, and V4 looks at the anterior portion of the heart. So V1 to V4 is going to give you more of an anterior picture. V5 and V6 is left lateral. So V5 and V6 looks at the left lateral wall of the ventricle. So it's left side. V5 and V6 is left side. So that's your 12 precardial Sorry, that's a 12 lead ECG. Now, this is my question. Process the information now. And let me repeat it before I ask the question. So V1 and V2 looks at the ventricular septum, so that's anterior. V3, V4 looks at the anterior wall of the left ventricle, so that's also anterior leads. So V1 to V4 looks at the anterior portion of the heart. V5 and V6 look at the left lateral wall of the ventricle, so it's left side. These 6 precardial chest leads combined with the 6 limb leads will give us a 12 lead ECG, but we're only using 10 electrodes, right? Now I can move, this is not you, I'm talking about a paramedic now. A paramedic can move the leads around to get more leads, so you can actually do what is referred to as a 15 lead ECG or an 18 lead ECG. You can also do a right side ECG because you don't get a lot of you don't get a full picture of the right side. You can do a right side ECG by shifting the electrodes over to the other side and swapping out V1 and V2. But that's not something you would be expected to do as an EMT. That's advanced stuff. All right. Now, we're doing a 12 lead ECG. When you're doing a 12 lead ECG, which electrodes would look at the right side of the heart? That's the first question. Not electrodes, which leads, I should say. Which leads would look at the right side of the heart? Some amount of guessing. It is clear as day. A, V, R, the R represents right side. It's only one lead looking at the right side. Can't be any other, right? So there's only one lead looking at the right side of the heart, and that's AVR. The AVR represents augmented voltage, right side. That's how I remember it. All right. Now, if you're doing a 12 lead ECG, and we're talking about all the leads now, chest leads and limb leads. If I'm doing a 12 lead ECG, which leads would look at the left side? 12 lead ECG. Which leads are going to look at the left side? It cannot be one lead, Mr. Duane. Can't be one lead. I haven't seen the correct answer yet. Still waiting. We're doing a 12 lead ECG. All of the leads we are consider now. If I'm looking at the left side, which leads? Still waiting on an answer. Still not seeing a correct answer as yet. You cannot have AVF in your answer. AVF is an inferior lead. Okay, so Mr. Jones has the correct thing. So if you're doing a 12 lead ECG, the leads that would look at the left side are lead 1, AVL, V5, and V6. That's your left side. So it would be lead 1, AVL, V5, V6 for a 12 lead ECG, right? That's the answer. If I am doing a 12 lead ECG, which leads would look at the inferior portion of the heart? Inferior portion. Don't take too long. Still waiting on the correct answer. If I'm doing a 12 lead ECG, which leads are going to look at the inferior portion of the heart? All right, so Miss Beckford Ford has the correct thing. Lead V3 and V4 cannot be in the inferior leads, it's anterior leads. So if I am doing a 12 lead ECG, the leads that look at the inferior portion of the heart would be lead 2, lead 3, and AVF. Thank you, Ms. Beckford. Final question. If I am doing a 12 lead ECG, which leads would look at the anterior portion of the heart? Okay, so anterior is V1 to V4. That's the easiest one to remember. So V1 to V4 is anterior. If you want to get more specific, V1 to V2 looks at the ventricular septum, V3 and V4 looks at the anterior wall of the left ventricle. Note that majority of the leads tend to look at the left side of the heart. That's the side of the heart that is prone to heart attacks. Doesn't mean that a patient can get a right side heart attack or a posterior side heart attack or an inferior side heart attack. But heart attacks are common on the left side. So that's your leads. That's what you need to learn, because you will see it again when you meet me face to face. So these are things you will need to learn. And what I have taught you is the basics. So this is not advanced stuff. This is basic ECG interpretation. All of this is basic. ECG is like mathematics. You have to learn the basics of maths, right? You have to learn the basics of subtraction, addition, multiplication, and division. And then you start to combine these principles. Same thing with ECG. So you have to know the basics of the ECG as it relates to the waveforms and what their representation, what they represent. And you need to know the difference between cardiac monitoring and doing a 12 lead ECG and what exactly the leads are looking at. So let's recap real quick. If we're doing a 12 lead ECG and we need to look at the left side of the heart, we're going to look at lead 1, AVL, V5, V6. If we're doing a 12 lead ECG and we want to look at the inferior portion of the heart, we're going to be looking at lead 2, lead 3, and AVF. If we're doing a 12 lead ECG and we want to look at the right side of the heart, we're going to be looking at V1, V2, V3, V4. If we want to get more specific, V1 and V2, ventricular septum. V3 and V4, anterior wall of the left ventricle. and that's your leads. So let me zoom out, right? So that's your leads. Now let's look at the ECG. Now I'm going to talk about the 15 and 18 lead ECG. Don't need to know that. Let's look at the ECG paper now. All right, so learn this part. Right, this is important. So the ECG is printed on a graph paper. Now, one small box represents 0.04 seconds or 40 milliseconds, and one large box represents 0.20 seconds or 200 milliseconds. Focus on the large box. So I'm going to make it as simple as possible. So this would be a small box. Where's my pointer? This is your, let me draw it out. You understand what it means. Oops, I want my pencil. So this is your small box. This is your large box, right? Now, if one large box represents 0.2 seconds, it means that 5 of the large boxes would represent 1 second. Okay, so that's what I really want you to grasp. If one of the large boxes represent 0.2 seconds, it means it takes 5 large boxes to give you 1 second. Now, if 5 large boxes give you 1 second, how many boxes would represent 3 seconds? Good, 15. So 15 would represent 3 seconds. If 15 represent 3 seconds, how many would represent 6 seconds? 30, right? So when you print out an ECG, you can print off what is called a 6-second strip. And what you use that for, you use that time frame to calculate the rate of the heart rhythm. When you're monitoring a heart rhythm, you use your lead 2. You can use any lead, but usually we use lead 2 to identify rhythms, right? Because it shows up all of the waveforms the best. You can look at any lead and interpret a ECG if you know what you're looking for. All right, now with that understanding in mind, let's apply the principles. All right, so let's apply these principles now. Remember your RR interval. Let's look at how we would calculate the rate for a rhythm now. So using the principle that you just learned, this is how you have the 10-second rule, you have the 20-second rule, you have the Swatin method, you have a whole heap of ways of to determine if your rhythm is fast or slow. So let's look at the 6-second rule. So you mark out 6 seconds on your ECG paper, which would be 30 large squares. You all mentioned that earlier. When you mark out your 6 seconds, on your ECG paper, you will count the number of QRS complexes within that 6 seconds, right? So we mark off 6 seconds, and we're going to count the QRS complex. 1, let me use my pointer. 1, 2, 3, 4, 5. So we have 5 QRS complexes within that 6 seconds. You take that number and multiply it by 10, and you'll get the heart rhythm. So if we have 5 QRS complexes within that 6 seconds and we multiply it by 10, the heart rate is 50 beats per minute. Can do it that way, or you can simply count by 10. 10, 20, 30, 40, 50. 50 beats per minute. Right, so that's a 6-second method. So I'm only going to show you 2 methods. Well, 3. Right? Then you have the Swatin method. So this method now is the Swatin method. There is a mathematical principle to work it out, but that would take me about 2 weeks to teach you. So we're not going down that path. We're going to SWAT for this one. So this is a Swatin method. And basically what you're doing is you look for where your QRS complex, so this is a sequence method, or a Swatin method as I call it. You look for a QRS complex that falls on a bright line, right? So this QRS complex falls on a bright line, mark that area, and then the next bright line is 300. The next one is 150, the next one is 100, the next one is 75, the next one is 60, the next one is 50. And this rhythm falls between 60 to 75 beats per minute. So it might be 64, 60, less than 65 beats per minute, but it's definitely over 60, so it's within the normal range. So that's the sequence method. Okay, that's the sequence. So again, look for a QRS complex that falls on a bright line, mark that off. Then the next bright line is 300, next one is 150, 100, 75, 60, 50. Wherever the next QRS complex falls, it will represent the beat or the rate. Now listen carefully now. I'm going to teach you the quick and fast method. So there is a quick and fast. So I can quickly look on an ECG and know if it is tachycardic or bradycardic. I can do that easily. Right? So I can look on an ECG and know right away if I have a bradycardic, a tachycardic rhythm, or a rhythm that's normal. So let me show you that method now. So look at your QRS complex, the peak. So I've marked that. This is the peak of your QRS complex. So look at that area. You are going to count the squares within that area. So 1, 2, 3, 4, 5. Right? Now, once the length of your QRS complex is between 3 to 5 boxes, or the RR interval, I should say. Once the RR interval of your QRS complexes is within 3 to 5 large boxes, you have a normal rhythm, right? So if it's within 3 to 5 large boxes, the rhythm would be normal. So let's say 1, 2, 3. This would be 3. So if I mark off 3, so let me mark off 3 that you can see. This would be 3. This is 3. What is 3 in line with? Note that 3 is in line with 100. So the rhythm would be the rate would be 100 beats per minute. That's 3 large boxes. If I mark off, if there is 5 boxes, 1, 2, 3, 4, 5. So 5 would be here. This is 5. So let me mark off 5. Right? 5 is in line with 60. So if it is within 3 to 5 large boxes, the rate is going to be between 60 to 100 beats per minute. Right? So I can know quickly if I have a normal rate. All right, now let me erase that. Now note this part. If the distance between the QRS complex is less than 3 boxes, sorry, is less than 3 large boxes, you have a tachycardia. Let me repeat that. If the distance between the QRS complexes or RR interval is less than 3 large boxes, you have a tachycardia. Let me mark that out for you. All right, so this is 1 box here, 1 here. So let me cut this one in half. That's where the next QRS complex falls. Note that it is greater than 100 at that point. So if I see that type of RR interval, I know right away that I have a tachycardia. Okay? Quick and fast. If the distance between the RR interval or QRS complex is greater than 5 large boxes, then I have a bradycardic rhythm. Right? So if it's less than 3, tachycardia. Greater than 5, bradycardia. Let's mark that off. Let's mark that off. One, 2, 3, 4, 5, 6. So let's mark this one. Right? So that would be greater than 5. Note that it is less than 60. So we have a bradycardia. So that's quick and fast. So that's your methods for determining the rate. And there are other ways to work out the rate, but use what I have given to you. Get comfortable with that one first. Right? So get comfortable with your 10-second method, sequence method. And as I say, you can use a quick and fast approach and know very quickly if you have a tachycardia or a bradycardia. It's not difficult. All right, now with that said, let's move forward. I'm going to teach you that method. So let's apply the principles now. All right, so this is your first rhythm. And don't necessarily look at the rhythm. Look at the ECG. So the rhythm, the type of rhythm is there, but focus on the ECG, right? Now, when you're going to identify a rhythm, you will look at the morphology of the rhythm, actual size. All right. So when you're going to identify a rhythm, choose lead 2. Look for your waveforms. So look for your P wave, look for your PR segment, look for your QRS complex, look for your ST segment, look for your T wave, right? So that's the first thing. Identify your waveforms. So is there a P wave? Is it consistent throughout the strip? Yes. Is there a PR segment? Is it consistent? Yes. Is there a QRS complex? Is it consistent? Yes. Is there a ST segment? Is it consistent? Is there a T wave? Is it consistent? So look for your waveforms. Then look at the width of your QRS complex and your PR interval. So the PR interval should be 5 to 3 small boxes in length. The QRS complex should not exceed 3 small boxes, and it should be less than 3 small boxes, and that looks okay. Now once you have a waveform like this where all the waves look pretty, the origin of the rhythm is sinus. So you have a rhythm that is sinus in origin. Now quickly look at this rhythm and tell me if it is a tachycardia, a bradycardia, or a normal rate. It's a normal rate, right? And if I want to be exact, let me be exact, 300, 150, 100, 75, 60. So it's between 60 to 75 beats per minute. So that's normal. So this is what we call a normal sinus rhythm. So everybody in this group should have a normal sinus rhythm unless something is wrong with your heart. So that's a normal sinus rhythm. So you need to know what a normal sinus rhythm looks like, because you're going to see it again. I can guarantee you that. Okay? For sure. So this is a normal sinus rhythm. All right, now let's look at this one. Now, can you see P waves and is it consistent? Oh, there's something I didn't point out before I move forward. You also need to check to see if the rhythm is regular or irregular. And when you're going to check if a rhythm is regular or irregular, you take a piece of paper. So you take a piece of paper and you mark out your QRS complex. So mark out the first 2 QRS complex on your paper and then move it along the rhythm to see if it match up with the other complexes. Note what I just said, people. Take a piece of paper, mark off the first and second QRS complex on that piece of paper and then move it down the ECG to see that all the complexes line up. This is the mistake that young med students make. They don't want to be seen with the paper because they were taught how to use the paper. Don't want to be seen marking off anything. So they're trying to look at a rhythm to determine if it's regular. Never ever look at the rhythm and say, yeah man, this definitely look normal or this look irregular. Get in the habit of marking off the complexes and moving it across the ECG. That's the correct way. That's how you're going to minimize errors. All right, now look at this rhythm and identify your waveforms. Can you see a P wave? Yes or no? Are we seeing a P wave? Quickly. Yes. Are the P waves consistent? Yes, they are consistent. Is every P wave followed by a QRS complex? Yes. Is every QRS complex followed by a T wave? Yes. Right? Is the rhythm pretty? It most definitely is. Is the distance of the PR interval and the QRS complex normal? The distance is normal. The distance is normal. Right? So the PR interval is within 3 to 5 small boxes. The QRS complex is less than 3 small boxes, so it's normal. All of the waveform is normal, right? So the origin of the rhythm is sinus in origin. Quickly look at the rhythm and tell me if it is a tachycardic rhythm or a bradycardic rhythm. So the distance, let's count that. 1, 2, 3, 4, 5, yes, 6. It's greater than 5 large boxes, so it's a bradycardia. Let's be more exact. 300, 150, 100, 75, 60, 50. So it's above 50 but below 60. Definitely a bradycardia. Because its origin is sinus, it is a sinus bradycardic rhythm. Now, a person can have a sinus bradycardia and nothing is wrong with them. It's normal because they are very athletic and their heart and lungs is well developed, so the heart doesn't have to work very hard to push the blood around the body, so they have a very slow heart rate. Or it can be something is wrong with the patient, meaning the patient has a cardiac issue and it is causing the heart rate to be too slow. So that's your sinus bradycardia. All right, now let's look at this one. Oh, not this one. Let's look at this one. Does it look pretty or does it look ugly? And when I say if it look pretty, I mean if you can see all your waveforms. So can you see your P waves clearly? Are you seeing your P waves? Yes. Are the P waves consistent throughout the ECG? Yes. Are you seeing your QRS complexes? Yes. We can see that. Is every QRS complex followed by a T wave? Yes. Right? Is the QRS complex width less than 3 small boxes? Yes. Is the PR interval within normal range? 5 to 3 small boxes? Yes. So the origin of the rhythm is sinus, right? Because you can see all of the waveforms clearly. It is sinus in origin. Now, is it irregular or regular? You use a paper, Miss Carr? How you know so quick? Hmm? How you know so quick? Gonna use a paper and mark it off? Okay. Okay. All right. So you have to use your paper and mark off and determine if it's regular or irregular. Now, quick and fast. Is it a tachycardia or a bradycardia? It's a tachycardic rhythm, right? And we will double check that. So this is the first QRS complex. 1, 2, definitely less than 3 large boxes. To be exact, 300 would be here. 150, it's very close, extremely close to 150 beats per minute, right? So it's very close to that. So this is definitely a tachycardia because it is sinus in origin. This is a sinus tachycardia. So you have sinus bradycardia, sinus tachycardia. Again, can be as a result of a physiologic process in the body, or it can be as a result of the cardiac muscle being affected. So you have to be able to differentiate if is a cardiac problem causing the tachycardia, or the tachycardia is as a result of something occurring in the body, like a patient going into shock and the heart rate going up. So that's his sinus tachycardia. Okay. All right. Now let's find a different one. So you need to know normal sinus rhythm, sinus tach, sinus bradycardia. You don't need to know atrial rhythm. So as an EMT, you don't need to know atrial rhythms unless you're going to do ACLS, and ACLS is really for advanced practitioner. But just look at this rhythm to see that something, what I want you to be able to do is pick up that something is wrong and it's not sinus in origin. So let's look at this one where it's kind of obvious. So look at this rhythm. Right? Does it look pretty? It's an ugly rhythm, right? So right off the bat, you know that this cannot be a sinus rhythm, right? Now, what did I say to you is happening if the P wave is not properly formed? Anybody remember that? If you cannot see a proper P wave, where's the rhythm coming from? While I'm young, people, while I'm young. Okay, thank you, Mr. Jones. So we now have a rhythm that is originating in the atrium. So this is an atrial rhythm. It's actually atrial flutter, right? So the atriums are trying to generate the current. You don't need to know this, so I'm not gonna be examining you on this. This is for persons who have done ACLS. And as I said, ACLS is not really for EMTs. You can do ACLS, but it's not for EMTs. The ones that I mentioned before, you definitely need to know how to recognize them. So you need to know how to recognize a sinus, bradycardia, sinus tach, normal sinus rhythm. Now look at this one as well. I just want you to be able to see the difference in the formation of the P wave. Look at this one. Does it look pretty or ugly? You realize you cannot see the waveforms clearly. It's an ugly rhythm. So you're not able to see a properly formed P wave. Okay, definitely atrial rhythm again. So it's originating from the atriums. This is what we call atrial fibrillation. Now, there's something very unique about this rhythm. Can anybody pick it up? Let's see if you're paying attention. What is obvious about this rhythm? Very obvious when you look at it. Quick and fast. Yes, it is irregular, but it is irregular, right? It's an irregular rhythm. None of the complexes are matching up properly. There's a lot of inconsistency. So it's the only cardiac rhythm that is irregular, right? Well, there might be others, but for now, for ACLS purposes, right, it's irregular. That's atrial fibrillation. Again, you don't need to know that one. So you don't need to know AFib and A-flutter. Not gonna be testing you on that. Okay. Now let's move to something that you definitely need to know. All right, so that's your fibrillation. And a patient with atrial fibrillation is at risk for stroke or heart attack. So when the atrium fibrillates, clots start to form and they can get a stroke or a heart attack. Look at this one. It is so fast that you cannot see the P wave. You cannot see the P wave any at all, right? So the P wave is lost in this rhythm. And it's extremely fast. So this is what we would call a supraventricular tachycardia, which basically means it's a tachycardia originating above the ventricles. Now, the term supraventricular tachycardia is used for rhythms that we cannot identify clearly where it is coming from. That's really what supraventricular means. We cannot specifically say where the rhythm is coming from. So they would need to slow it down to see exactly where it's coming from, because as I said, the P waves are being swallowed up. So this is a supraventricular tachycardia. What is common with a supraventricular tachycardia is the Qrs complex becomes very narrow, and it is usually over 150 beats per minute. Not something I would expect you to know as an EMT. I'm just showing you the waveforms for you to see that you can have, when the basics is not present, the rhythm is coming from somewhere else. All right, so that's an SVT. Don't want to show you that one. Let's look at a premature ventricular contraction, because that was in your cardiac chapter. So I want to show you that one. All right. Let's look at, all right, so look at this rhythm, right? And this is to give you an example of how subtle the changes can be. Now, does the rhythm look pretty or ugly? That's the first thing. Is it an ugly or pretty rhythm? Quickly while I'm young. It is pretty. All right. Can you see your P waves, and is it consistent? Right, so there is consistency. Is there a PR segment, and is it followed by a QRS complex and an ST segment? Right. Can you see a T wave, and is it consistent? All right, good. Is the QRS complex normal? Is the QRS complex normal? Yes, it is. Now, this is the subtle change in this rhythm. So this is what is different. Is the PR interval normal? That is what is different in this rhythm. Is it normal? So this is where the PR interval begins. This is where it ends. Is that 5 small boxes or greater than 5? It's greater, right? And that's the only thing. Well, there's something else that's different with this rhythm as well. So that's one key finding. So that's a key finding, right? And really, it's the only thing that's different for this. Now, what did I say is occurring if the PR interval is greater than 5 small boxes? What did I say is occurring? If the PR interval is greater than 5 small boxes, you have a heart block. Something is blocking the impulse. Something is causing a delay in the impulse. This is a patient with a heart block. This is a first-degree heart block. Not something you're expected to know. I'm just using this as an example to show how subtle the changes can be. So you have to know what you're looking for. So you cannot forget the fundamental principles. You have to look for everything, right? Just like maths, you can't forget your fundamentals. You have to look for everything because it might be just one little thing that is different. Okay. All right. So that's not, you don't need to know your heart blocks. So not going to spend time on that. All right. Ventricular rhythms. So these, the ones I'm going to show you now, you need to know. And there's something that is very unique. So this is the first one I'm going to show you. So does it look pretty or ugly? This is the first one. It's an ugly rhythm because you cannot clearly identify your waveforms. As a matter of fact, there is no P wave, there's no PR interval. The only thing you can recognize is the Qrs complex, but look at how wide the Qrs complex is, which suggests that the rhythm is ventricular. So when we have a wide Qrs complex, what does that mean? It means that your rhythm is ventricular in origin. Now quickly determine if it's a tachycardia or bradycardia. Is it a tachycardia or bradycardia? It is a tachycardia. To be exact, 300, 150. It's very close to 150 beats. So this is what we would call a ventricular tachycardia. Patient can have a pulse can be absent. If the pulse is absent, the patient requires CPR and defibrillation. So this is a ventricular tachycardia. Definitely need to know that one. All right, now look at this one. Pretty unusual looking rhythm. It's also referred to as Torsade, which is French for twisting points. Can you see your waveforms? Is it ugly or pretty? It's an ugly rhythm, right? You cannot clearly identify your waveform. The only thing you can really identify is your Qrs complex. And they are wider than 3 small boxes. So the Qrs complexes are wide. But it has a what's the word? It has there's a word, man, I'm trying to remember, but for some reason my brain won't allow me to remember it. Let me backtrack a bit. Okay, right. It has a polymorphic presentation. That's the word I was trying to remember. Right? So no. Is it a tachycardia or a bradycardia? We know the origin because it has a wide Qrs complex. So it is a ventricular tachycardia, but it is what we would call a polymorphic ventricular tachycardia. The one that you saw before is a monomorphic tachycardia. Now, again, this patient will not, these patients tend to not have a pulse, and you are going to provide CPR and defibrillation as needed. This patient will need a specific medication, which can only be administered by a paramedic or higher, right? So this patient will definitely need ACLS early in the field. More than just shock therapy is needed for this type of VTAC. So that's a polymorphic VTAC. The previous one was a monomorphic. Definitely need to know those rhythms, okay? All right, now the term premature ventricular complex. So this is a rhythm, and this is why I always ask you this question. Do you see your P wave? Is it consistent? So if you look at this rhythm, do you see consistency in your P waves? No. No, there is no consistency, right? Here is a P wave, and if I mark off this P wave and this P wave, if I mark these two P wave off on a paper and move it down where the next P wave should be, it's not there. It's not consistent, right? So there is inconsistency here. There is something going on right here. Now, what has happened is we see a new waveform, but what is unique to the waveform? It is a QRS complex and it is wide, right? It is a QRS complex and it's wide. So where is it originating from? If it's a wide complex, where is it coming from? The ventricle. So this is what we call a premature ventricular contraction. So this is a premature ventricular contraction. It is the ventricle is contracting too early, and that can cause problem. Why? Remember that the impulse has to slow down to allow blood to enter the ventricle. So if the ventricle start to contract when there is no blood to push out, we're gonna have a problem. So if this continues, eventually the patient is going to go into what we call a runoff ventricular tachycardia, runoff VTAC, right? So that is why I always asking you, is it consistent? Very important. So that's a premature ventricular complex or contraction, right? Don't need to go into in-depth stuff with that. Now look at this one. You have seen this rhythm before because I drew it earlier, right? Now, can you see anything at all? There's nothing I can identify clearly in this rhythm. So I can't see P wave, I can't see a proper PR interval, can't identify any clear QRS complex. The rhythm is irregular, right? It's chaotic. It just looks very chaotic. This is your ventricular fibrillation. Must know this one, right? So this is a must know. Need to know ventricular fibrillation, ventricular tachycardia, sinus tachycardia, sinus bradycardia, normal sinus rhythm. And I'll show you what a PVC look like. I'm not gonna test you on a PVC, even though they put it in your textbook, but you should know what it represents, okay? So this is ventricular fibrillation. If present, no pulse, no breathing, patient requires CPR, early defibrillation, early ACLS, and definitive cure. So that's your VFib. Now you can get tricked in the field. So don't let this happen to you in the field. So look at these two rhythms. So look at both of them, right? What is the top one? What is the bottom one? So what does the top one look like to you? What is the bottom one? Give me a response. While I'm young. What does the top rhythm looks like? What does the bottom rhythm looks like? Quickly, people, come on. Either wrong or right. Don't have all day. Give me an answer. All right, so one person said the top one looked like ventricular fibrillation. Correct. So the top one does look like ventricular fibrillation. What does the bottom one looks like? The bottom one looks like a flat line, right? Which is asystole. Now, anytime you have a patient on your cardiac monitor and you see something that looks like asystole, the first thing you do is you check your patient. So once you see a rhythm change, is there a pulse? So check your patient to see if you have a pulse. That's the first thing. 2, then check to see if your electrodes are properly attached to the patient. So 1, check the patient to see if there is a pulse. Check to see if your electrodes are properly attached to the patient. And then switch your lead. So if you're on lead 2, switch it to lead 3 to see if you see the same thing, and you can also turn up the gain. Now, the bottom one is what we see. So we see this as the bottom one, a flat line, something that look like a flat line or asystole. Check the pulse. When I check the pulse, there is no pulse. When I check my leads, they are properly attached to the patient. When I switch to lead 3, I still see something that looks like a flat line. When I turn up the gain, I see the rhythm that is at the top. So when I turn up the gain, I see the top rhythm. So this one that is at the bottom is actually ventricular fibrillation as well. So both of them are ventricular fibrillation. One is fine VFib, the other is coarse VFib. So once you see asystole, don't assume that it is a flat line off the bat. Do your checks and make sure it's not a fine VFib, because if it's a fine VFib, patient requires CPR and defibrillation. Okay, so that's that. All right, now using that principle, this is what we see. What's the first thing we need to do? So on our lead 2, this is what we're seeing. What's the first thing we need to do? Don't have all day. Check the pulse. There is no pulse, right? So there is no pulse. What's the next thing we need to check? No pulse is present. What's the next thing? We need to check the leads. So we need to check to see if the leads are properly attached to the patient. Leads are properly attached. So leads are good. What's the next thing we need to check? What is the next thing that we need to check? We have checked the pulse. Pulse is absent. We have checked the leads. Leads are attached. We need to switch to another lead. Switch to another lead. And when you switch to another lead, you're still seeing asystole. And what is the last thing that we need to do? So we check the pulse. Pulse is absent. Leads are good. We switch, still seeing a flat line. We adjust the gain. When we adjust the gain, we're still seeing a flat line. Which rhythm is this? So we have done all the checks and the rhythm has not changed. Which rhythm would that be now? This is your asystole. Don't tell me no flat line. This is asystole. That's the correct term. Learn it. So this is what we call asystole, and this is where we're going to call the code, right? Yeah, especially if it's sustained asystole. Right, so it's an absence of electrical activity. No. So these are your rhythms that you need to be familiar with. Normal sinus rhythm, sinus bradycardia, sinus tachycardia, ventricular tachycardia, ventricular fibrillation, asystole, and there is one last one. So one more. Let me find a rhythm that looks normal. I want something that looks kind of normal. All right, so let me use the block. So I'm going to use a rhythm that has a normal morphology. So you have your patient on your cardiac monitor and you see a rhythm change. So there is a rhythm change. First thing we need to do is what? If we see a rhythm change on the monitor, what's the first thing we need to do? Come on, I don't have all day. Answer the question. We need to check our pulse. Okay? When we check the pulse is absent. So there is no pulse, but we're seeing that rhythm on the monitor. What is this rhythm? So no pulse is present, but we can see that rhythm. What is this called? Mentioned it earlier before we went to lunch. Can anybody figure that one out? Any answers? Okay. Nobody wrote that one down. All right. So you see a rhythm change with good morphology, and the patient has a pulse. The patient doesn't have a pulse. This is what we call pulseless electrical activity, PEA. So this is a PEA. It's any organized rhythm that does not produce a pulse. So if you see that and there is no pulse, the patient still require CPR. The AED will not indicate a shock because it's not a shockable rhythm. So the electrical activity of the heart is fine. The blood is just not moving, whether it is being caused by a PEA, pulmonary embolus, or a coronary thrombus. Something is blocking blood flow within the heart. So that's the last one, pulseless electrical activity. So you have PEA and you have asystole, you have your VTAC and your VFib. You have your sinus bradycardia, sinus tachycardia, normal sinus rhythms. These are the rhythms you will be expected to know when you come for your face-to-face session. So I'll have a sheet, a worksheet for your ECG stuff, and your goal is going to be to write what the rhythm is, right? So you'll see the waveform, you write if it's a sinus rhythm, you write if it's a sinus tach, sinus bradycardia, ventricular tachycardia, ventricular fibrillation, PEA, asystole, depending on which rhythms I give you. Right, so that's it for your basics for the ECG. I don't think there is anything else I would need to cover from this for this section. So I think that's it. I think we covered everything.